Hello. All right. Hi, everyone. I'm just going live on, there you go, on Instagram. Hello, everyone. This is Dr. Amigues, your friendly rheumatologist. I'm outside today, and I'm going to talk to you about mixed connective tissue disorder. We're going to look at how we diagnose it and what's the difference between the different variation. Hopefully, my camera works, my audio works. I have a little bit of an inflammation of the eye, so I'm really sorry, but I just didn't want to cancel this Rheumatology 101 live. Okay, so bear with me, and hopefully you're listening more than you're looking. The last time we talked about UCTD last week, so if you're ever interested in looking at other of the rheumatology lives, they are all staying in the YouTube video Rheumatology 101 by Dr. Isabelle Amigues, Amigues. Subscribe, like, comment. I look at comments. I don't look at them all of the time because I try to limit my social media use. But I definitely look at them and they give me some ideas for new topics. So, for example, the UCTD was someone that was asking for that topic. And then I thought, okay, we don't ever talk about MCTD. And I'm sure that that's something that you've heard in the past. So let's talk first with. I want to share a case because I think that those are actually so fun to discuss, and then they are much more visible and much more clear to get a sense of what's going on. So, um, when actually I'm going to share the first time I've ever saw MCTD. So it was like more than 20 years ago, and I was in France, in Paris, and there was a patient that was hospitalized because she was a very high smoker. So she was smoking quite a bit. She was in her 50s, early 50s, and had very swollen hands, extremely swollen hands. In fact, so swollen that you couldn't actually there was no more, it was very hard for her to move her hands. She couldn't, like, we have something called the prayer sign where you can't do like this, and you have to like move your hands like that. You cannot do the prayer. um she had also a little bit of pain, but mostly really what was bothersome for her was the fact that it was so swollen. And um she had a little bit of joint pain otherwise, but really the main issue was this swelling of all of her fingers, and this tightening of her skin. And basically we do a workup. We make sure that it's not paraneoplastic, because when someone is smoking, you always want to make sure that it's not something that's related to cancer. And then we basically find this positive antibody, which is called the RNP, UIRNP antibody. And so if you don't look for it, you don't necessarily find it. So ANA, I think the ANA was positive and the UIRNP was positive, but all the other things were negative. The sDNA was negative, the rheumatoid factors, CCP were negative, everything. X-ray didn't find anything. And so basically we make the diagnosis of MCTD. Okay, so mixed connective tissue disorder. You've already heard me say that I don't like this term because it doesn't reflect exactly what this is. I think a much better term would be autoimmune disorder, rheumatologic autoimmune disorder. We're never gonna, it's not easy to change the way, because we learn things and we learn so much in medicine. So it's really hard to change names, right? Like, even I'm guilty of that. I still talk about Wegener and Strauss, and it's hard. I know, the different names, but it is hard to change names. But it doesn't really matter, actually, honestly, how we call it. The most important is to understand the process. So mixed connective tissue disorder, MCTD, is a group of autoimmune disease, rheumatologic autoimmune disease, that look like rheumatoid arthritis or lupus or scleroderma, but that don't have all of those features. So now you're like, well, this is the same than UCTD, undifferentiated connective tissue disorder. Well, it is different by one thing. They have this positive RNP antibody. And because they have this positive RNP antibody, then you can call them MCTD. But it's basically a UCTD with a positive RNP, but without yet other antibodies, without yet other um, uh, uh, clinical manifestation. Okay, so let's say for these patients that we're discussing that had this very swollen hands, very like skin tightening, just the hands. If you actually think about it, it's actually looking a lot like scleroderma. I'll do a live on scleroderma if I haven't done it, because I think that's important. It's a very rare disease, but it's actually important for us to know what this is. So scleroderma, autoimmune disorder, and it affects the skin, affects other organs, of course, but in this case, affects the skin, and it's going to tighten the skin so that you don't see the folds anymore, and you cannot use your joint, not so much because of the joint per se, but because the skin is so tight. So, for example, think of you've done a hiking for a long period of days, and your hands have been like done for many hours. And if you actually were to look at your hands, they would be swollen. They would be a little bit tight, not much, but a little bit, right? So imagine this worsen, and that's what we call sclerodactyly. Sclero means sclerosis, dactyly means finger. So fingers sclerosis, which means basically that you have almost like a thickening of the skin of your fingers, and that's problematic, right? So that's autoimmune, meaning that we know that it's an autoimmune process. And so what you want to do in those cases is, help the immune system get back into rebalance. So this is one symptoms of MCTD. So that's like the scleroderma part. That's probably what this patient that I was discussing at the beginning had, right? And then you have to follow them. You have to follow patients because with time, they actually might develop full-blown scleroderma. So you want to prevent that, and you also want to make sure that that's not what that they develop ultimately. So that's that. Then you can also have the lupus presentation. So you're going to look: do they have hair loss and patches? Do they have a malar rash? Do they have ulcers in their mouth or in their nose? Do they have shortness of breath? Fluid around the lungs, fluid around the heart, joint pain that's inflammatory. They can present like that. The difference usually is that they don't fulfill the criteria for lupus. Otherwise, you would say, yeah, you have a positive ANA, even if it's a RNP positive, you have all of those symptoms, then you have lupus, right? So we usually, it's usually they don't fit all of the criteria for lupus. And then you can also have patients who have inflammatory arthritis with synovitis, so the inflammation of the synovium, which is the pocket that surrounds the joint, right? And they have no rheumatoid factor, no CCP, but they have this RNP, that's antibody that's positive, and that is something that you're going to be like, okay, do those patients ultimately develop full-blown rheumatoid arthritis? So overall, right, the way we approach this is we have a patient with some symptoms that look autoimmune, that look rheumatologic autoimmune. They have joint pain that's inflammatory. They may have skin rashes. They may have hair loss. They may have severe fatigue, fever, lymph nodes that are swollen. They may have ulcers or their mouth or their nose. They may have shortness of breath, chest pain. Right? Like basically, kind of like this whole array of possibility of symptoms. They don't have all of them, because if they were to have all of those, then you would have like, okay, this is probably lupus, right? But they don't have all of them. It's like you're almost there, and they have a positive RNP. And if they have a positive RNP, that's when you say, okay, you have mixed connective tissue disorder, MCTD. The treatment, and I'm going to go right away for the treatment. We usually start with hydroxychloroquine or Plaquenil, or sometimes we call it HCQ, because it's going to help rebalance your immune system. Okay. And so the idea is to rebalance the immune system so that we can prevent any further progression into a full-blown rheumatologic disorder such as scleroderma, RA, or lupus. Either way, we're going to follow patients that have this to make sure that they do not develop the full-blown uh, um, um, disease, like condition, and make sure that they don't need more than just the Plaquenil, which remember, is not immunosuppressive. It really just balances the acidity of the cells and rebalances the immune system. Okay, so I hope this is helpful. You know, the goal of all of those Rheumatology 101 is to simplify so that everyone understands. I think rheumatology is a when you don't know rheumatology, it can look very complex. And then you don't know what is rheumatologic, what is autoimmune, is it autoimmune, is it, you know, and the truth is that rheumatology is usually autoimmune, right? But then you have to, like, in my view, take something that's complex. There's no question that rheumatology is a complex field. That's what makes it so intellectually satisfying as a rheumatologist. And we can also simplify it so that we know what we're dealing with on a regular basis. And that's really what I'm trying to do with this Rheumatology 101. So we're going to end this one here. I hope this was useful for you guys. If you have a topic that you're interested in, don't hesitate to comment. If you're listening and if you've been watching this as a later on as a replay, put an hashtag replay so that it puts up on the platform so that other people that may actually have MCTD or don't know, or maybe they don't know and they want to learn, they can learn, and then share with people that you think would be liking those videos. It's my passion. I love educating, and I'm really excited and very grateful to be here with you all. Until then, I will say goodbye. I see that Dana has joined, Haver, um, and Fatane Ansari has joined as well. Thank you so much, and I will see you next week. Have a wonderful day. Bye bye.